for that, we need to reframe our thought process. We need to rethink, that means. So, Dr. Om, how has the EASO journeyed till here? What has their thought processes been while they have thought about reframing obesity?
So thank you for that question, sir. I think this EASO conference, and I think for the audience, if they go back and look at the papers presented here or the discussions here, I think it's landmark. There are a lot of significant changes which have, occurred with this conference, and it will define obesity in the future. And there are two things which are absolutely, vital for us to understand reframing of obesity. And, this is going to be repeated in the next rest of the session as well. But I'll state right in front because it's very, very important, and I hope that, the audience learns more out of it once it's repeated. So first and foremost, I think, what they've said is that BMI, like we already discussed in the first question, that it should be chucked away and maybe replaced by something better. Now, what is better? That's still not very clear. But one potential, marker, which is very interesting, is waist to height ratio. Very interesting, right? So in fact, repeatedly in this meeting as well and in the EASO conference and other places, they have focused on this as a new marker, waist to height ratio. It's very simple to calculate. You should just know your waist size, right? And for most of us, it's the same size of the pants that we wear, right? And we all know our height, right? So all you need to know is that if your waist is more than half of your height, then you're obese, or then you have a problem. It's very simple. So, you go to shop for your favorite set of pants next time, you actually know whether, you are in a problematic situation or not. The second thing, I think which is very important, though it's a technicality, it's very important if you see in a broad context. And what they've done is they've actually redefined obesity in a lot of sense. And obesity was considered as a risk factor. So whenever even in MBBS, when you're taught medicine, it was like, what are the risk factors for diabetes? Somebody would say obesity. Or what are the risk factors for osteoarthritis of the knee? Somebody will say obesity. But now they say it's not a risk factor anymore. It itself is a disease, right? Obesity itself is considered as a disease. Now, why this is important is because you don't have to wait for the patient to develop osteoarthritis. You don't have to wait for the patient to develop diabetes. You don't have to wait for the patient to go to Dr. Kamal Sharma before you start treating the patient. You start treating the patient right at the point when you start having the patient understand obesity. So I think that is a very important aspect. And the third very interesting aspect is, and this term again, which is going to be repeated in the rest of the meeting again, is something which they call as ABCD. That is Adiposity-Based chronic disease, right? So again, maybe moving away from the word obesity itself, why don't you call it as a disease of adiposity, right? Now, obesity itself, it's basically fat, right? But we all know that now it's not just the fat, but where this fat really gets distributed is equally important, right? So hence, I think, now again, they are focusing on more of considering adiposity, considering where this fat gets deposited in correlation with the complications that we can expect, right? So these are the reframing, rethought. I think it's a very important, meeting. I think, in years together, maybe after a decade also, we'll remember this meeting as well. Yeah. So I think it's pretty much a landmark thing.
So, Dr. Om, we speak about so many phrases in English now, obesity versus clinical obesity, normal weight obesity, metabolically healthy obesity. Then we added longitudinal and cross-sectional. So, two simple questions put together. Adiposity and obesity. What is the difference? What is the similarity? Two questions. And then when we put it together, how does the concept of adiposity redefine obesity for us?
Right. So I think, as we alluded so far, we need to understand that just having fat or just having a particular high BMI does not put you in a disease state. It's a surrogate marker of something which is going on internally. Now, what is more important is that the fat that gets distributed in the visceral, around the viscera, which is known as visceral fat, or the fat which gets, surrounding some of the important organs, that's the ectopic fat. These fat are metabolically active. And these are the ones which cause the disease, right? So the disease is caused by the ectopic fat. The disease is caused by the visceral fat. Unfortunately, Indians tend to have more of this visceral and ectopic fat. So we are, even at a lower BMI, we tend to have more of the disease attributable to obesity. Now, in that sense, and if you see this guideline and this conference, there was a lot of focus on adiposity, focus on the fat that it's not just important to, know that you're fat or know that you're obese or know that you have a particular number which you cross in terms of BMI. It's also very important to know where does this fat really lie, right? Does this fat really lie in the viscera, right? Does this fat really lie in surrounding the important organs of your body? Because if you have that fat, that's the one which is going to produce the disease. So while we understand that obesity in itself is a disease and obesity in itself is a problem, the fat which is distributed inside the body is the one which is more problematic, right? And some way we need to either measure that, and in some way we can, if we could treat it, right, selectively maybe, then we are, solving a problem, right? So I think what they're saying is that we should probably start using the term adiposity or the term ABCD more often to convey the importance and convey the severity and convey the importance of this disease. Because if we do not do that, I think obesity will still be taken as, and I think, sir, in northern India, I remember, I did my training in Delhi, and young children, obviously obese, they'll be brought by their, parents, and they'll say that, mera bachcha thoda healthy hai, right? So the euphemism for obesity was healthy. It's hardly healthy, right? It's actually unhealthy. So I think, that is where we move away from these euphemisms and this notions that we have of obesity and move to the fact that adiposity is a disease in itself, right? And that's something which we need to recognize and take it serious.
Another term that we use in India is Baro phenotype. And that is basically Baro plus phenotype. It's a portmanteau. So the phenotype may vary from person to person. You may be able to see overt and obvious obesity in some people, but not in others. Even those others, they will have a lot of adiposity in their viscera, surrounding their viscera. So like one way of checking for it is the waist circumference. Another, like Dr. Om said, is the waist circumference divided by height. And other, of course, we have imaging tools also now which can help us pick up adiposity. So, but we really need to, yes, carry on.
Yeah, sorry. Sorry to interject, sir. This thought about that sumo wrestler paradox, right? So sumo wrestlers are athletes, right? The Japanese sumo wrestlers, they're actually athletes. They probably exercise more than any of us do. They try to keep themselves fit, but they are, in a conventional sense, if you look at them, right, they're obesity, right? They're obese. I remember that there used to be, when we were children, there used to be an, sumo wrestler in WWE, which we used to make fun of, right? But that guy is probably more healthy than us, right? A sumo wrestler paradox actually tells you that they have more of subcutaneous fat, but they have less of ectopic and visceral fat.
Less of visceral fat.
Though, a Yokozuna, who is a sumo wrestler, who looks more obese in a conventional sense, is probably more healthy than, me. Right. So I think that is what really drives that paradox. And that is where, we need to start seeing obesity, not just from an Instagram and social media perspective from who looks obese. We need to see a little bit underneath. And that is what, I think is a very important message I think to us.
That's what Baro phenotype means. Yeah. And our Kabaddi players are also like that. So another quiz question for everyone. In this year's Pro Kabaddi League, which team won the medal? Which team stood first in the Pro Kabaddi League? My favorite team stood second, unfortunately, but it's a great team. I still cheer for Haryana Steelers. There's another aspect to it also. We have a very strong showing with semaglutide, a very wide spectrum of beneficial effects. But what about sustainability, Dr. Om? What was the long-term weight loss data that was shared at ECO 2024 from the SELECT trial?
So let me ask all of you, what is more difficult than losing weight?
Maintaining.
Continuing.
Maintaining that. In fact, if losing weight is 1x, a problem, maintaining that same weight that is lost is 2x of a problem. It's a big problem. Goes back to Newton's first law of motion, right? That, a body tends to stay in a state of rest unless it is acted upon by an external force. Inertia, right? We all know inertia. So the human body is actually a lump of rock. The size of the rock may differ depending on your BMI or now waist height ratio rather. It will want to be in whatever state it is, right? And in fact, it goes both ways. Somebody who's trying to gain weight also finds it equally difficult to maintain the weight which is gained, right? It's actually equally difficult. Now, we don't know why, right? There are, after so many years of understanding obesity and we have been researching, there are still debates on why that happens. Some people call it a metabolic handicap. Some people call it body's inertia. Some people call it homeostasis. The point is that the human body wants to be in the state which it is in, right? Unless, you radically change the entire equation. So one of the major challenges with every form of, things you have tried for losing weight, including dietary interventions, including exercise, was that you had this typical hockey stick pattern, right? Whenever you lost weight, and then you lost weight for a while and it stayed there, and then you went back again, right? Went back again. Maybe you reached the state where you started with, right? That's what ultimately it is. You somehow magically the body goes back to where it all started, right? Now we don't know why, right? There are many reasons. So the early, anti-obesity agents also suffered from the same problem, that you lost that weight, whatever orlistat or whatever drug that you use, you lost that weight, rapidly you lost that. And then you again started gaining back and again reached some state, maybe just close to where you started with. So the point is, if you move around in circles, how is it going to help you, right? I mean, it's not going to help. So that was always a challenge with this newer generation anti-obesity drugs as well, right? The GLP-1s. So one of the major challenge was that, fine, it's great. The shares of these companies are on the high, and you have, a lot of people, including celebrities, including Elon Musk, tweeting about using anti-obesity drugs. But does it sustain the weight which is lost? That's the $1 million question. Now, we don't know for eternity, right? We don't know whether it's going to sustain you for the rest of your life. But now we have a follow-up study which was presented in the European Congress, which actually showed that up till a period of about 4 years, you actually maintain the weight. And not only that, there's a tad bit continued reduction in that weight also, right? So you started with about, maybe losing rapidly, maybe 10 to 15%. But even at the participants who continued to use the drug, even after 4 years, they continue to maintain that level of weight that was lost. So I think more than GLP-1, I think the big breaking news here should be that we all know, now everybody knows, everybody on this planet knows what, these drugs are and how do they act and, how do they really work. But the question always remained, does it sustain? And the breaking news now is it does, at least for the next 4 years. Right? So if you are on this drug and if you continue to take it religiously as probably should, then you will maintain the weight that you lost, and you will continue to maintain the benefits which you get from the weight loss. So I think that is the that's the answer. I could have just said yes, but
that is reassuring. Obesity and diabetes, are they related? Are they twins? Is one of them the elder brother or sister? Which came first, the chicken or the egg? And what is the data for prevention of type 2 diabetes with AOMs?
So, sir, before I go into that,
carry on, and we'll wait for the answers as well. But carry on, and we can get the answers later.
So, you talked about the benefits of obesity in general. That's what we are discussing. For all of us, obesity as clinicians, obesity means a lot of things, right? For me, it could mean prevention of diabetes. For Dr. Neeta Deshpande, it could mean, reduction of chronic inflammation. So for all of us, it means something very different. Most of your patients, when you're treating them for obesity, they just want to fit into that dress which they bought for the next wedding. That's all it matters to them, right? So, so the point being that, we may see patients, from a clinical perspective, patients' preferences are often very different. So the good part about obesity is that this is something which can actually, for all patients to really fit into the dress which they wanted to fit into, right? At the same time, get all the clinical benefits which you can get from, right? Again, for years together, we have been crying hoarse about strategies for preventing diabetes. Every conference or every presentation you have about diabetes, it always starts with the prevalence of diabetes in India, the future projected numbers for diabetes in India, which are all very, difficult to really digest. The reality is that we need to prevent diabetes. That's the first thing. And, to prevent diabetes, I think one strategy is not just obesity, in fact. It's actually adiposity, right? So you need to reduce that ectopic fat, the fat in the pancreas, the fat in the liver, right? If you see, most of the recent discussion, and Dr. Neeta Deshpande would agree with me, the twin cycle hypothesis of Freud-Taylor. The point is, if you cut the fat from the pancreas, you cut the fat from the liver, you have, less insulin resistance, beta beta cell function, and then you have the obesity, the diabetes itself going away. So, which came first? Naturally, adiposity came first, right? There is no doubt about it. In today's world, it would be sad to say that diabetes leads to obesity. No, it's always the other way around. It's obesity leading to, or adiposity leading to the diabetes. Diabetes is a consequence. It's the downstream effect. So that is for sure. And hence, the question which it is always pegged to us, and this is my philosophy for a long time, we probably start treating diabetes and the complications with diabetes too late. And I think the time to actually intervene seriously is in that pre-diabetic metabolic syndrome phase. That's the time you start intervening, because though the microvascular complications start developing once you start developing hyperglycemia, the macrovascular complications, the route towards a EASCVD starts in that pre-diabetic metabolic phase. So I think it is very important that we recognize that this phase is very important from long-term cardiovascular prevention point of view. And hence, if you see any obesity, in fact, most anti-obesity medications have shown improvement in the pre-diabetes to diabetes conversion. That is there. I'm 100% sure you take any GLP under the sun, right? You will find the same data. And that has been proven in a lot of studies which is there, right? So I think it's now, I think, and the audience does not need to be told that anti-obesity, especially GLPs, are definitely going to prevent the pre-diabetes from going into diabetes, for sure. I think there is no doubt about it, right? Not only remember, while we're discussing this, anti-obesity drugs in the GLP spectrum are also the most powerful anti-diabetic drugs in that spectrum as well, right? So even if you do develop diabetes, it's the go-to drug for you there as well, right? So the point is, I think we need to probably move away from the 6.5s and 7, I'll only treat my patient or I'll only take my patient seriously after he becomes 6.6%, right? We need to take our patient seriously when he comes with a 5.8%, with a triglyceride of 250, with a waist height ratio of more than half. That is where you start taking your patient seriously, and that is where you start intervening, at least, putting the seeds of prevention at that point of time. So that's the whole idea.
And that's the power of, at ECO, other benefits of anti-obesity medications were also discussed. So what about arthritis? Now, obesity is a risk factor for arthritis, but arthritis prevents us from exercising. So it's a very catch-22 kind of a situation. How do we come out of this?
Yeah, I think very interesting. If you see, a lot of times we learn some little principles from the colleagues in marketing, in the business field. And if you look at a lot of these companies who are making this anti-obesity drugs and who are, envisioning it to market in the field, they, one interesting, I had a discussion with a marketing colleague, and he said that, we're also looking at orthopedic surgeons to market this. What has orthopedic? Recently a friend of mine, tweeted something very interesting regarding orthopedicians learning ECG. So it's, if all the spikes are up, you can operate. If all spikes are down, you can't operate. That's, or if there are no spikes, you probably, the patient died a few. So that's, making ECG simple for orthopedic surgeons. But, where does really anti-obesity drug really drive in terms of, orthopedic surgeon? What is interesting is that once I started getting patient being referred to me by orthopedic surgeon, that, this person needs to lose weight so that I can operate on him or her, was when I realized that's such a big problem for them as well, the osteoarthritis. So now the problem is you have an aging population. Not only you have aging population, you have an aging population which is obese. So you have obese aging population, right? So now they have, the joints are gone, yet the weight they have cannot support the joint, right? And for the best outcome, an orthopedic surgeon or joint replacement surgeon wants the best outcome for his patient or for her patient. The point being that the best outcome can only be delivered when the load is less, right? Again, simple physics. So it's to the benefit of orthopedic surgeons, to the benefit of the patient, that the patient loses the weight. And if the patient loses weight, the outcome for both, preventing a surgery, which patients want, or if you do perform a surgery, preventing the complications of surgery, or preventing the intra or perioperative complications, and finally preventing, having the sustainability of the surgical outcome, is all determined by what the patient's weight is, right? And in that case, again, that alone itself, is a big chunk of patients who can actually benefit from weight loss, right? So again, this is actually a dissertation, a thesis of one, student, which actually gets a very interesting take on this, that you can actually have joint knee osteoarthritis prevented as well as, better managed with weight loss. So I think that's something which is very important. And again, having to put this, see, there are things which a lot of patients accept a lot of therapies which improve their quality of life. We don't really realize this. I think that is where SGLT2 also really took, there are a lot of patients once it started, and, Dr. Kamal Sharma, we had discussions several times on this. Patients immediately felt better. You had a patient with a heart failure, you give them an SGLT2, the patients feel better. And the patient is then more likely to continue that drug. Patient doesn't really care about, what clinical outcomes you are trying to get. What he really cares about how he or she feels. So that is where, again, once the patient starts losing weight, even if they would probably never knew that they had a joint problem before they started losing the weight, and now they know that they can walk better, right? So that is, I think these kind of things, which actually improve the quality of life is something which is quite, remarkable. And that is something, that's why the patients are going to continue those therapies, even if they maybe come at whatever cost it may come at.
And this is a good idea, a good opportunity for us to practice our history taking, our person-centered care skills, person-centered medicine skills. Until you take a good history, until you listen to the patient, you don't know what is important for her. Yeah. For one person, it may be a risk of breast cancer. For another person, the fear of heart disease. Yeah. And you take those histories, but you forget to talk about the knees. For another person, it may be just a knee pain or the fact that she wants to play with her grandson. So if you say that, yes, madam, we can help you reduce your weight, this will help you improve your quality of life, you will be able to dance at your granddaughter's wedding. Now, that might be a motivating tool for someone to begin losing weight with or without drugs. So, dancing at grandchildren's wedding, that is something that would appeal to many of our patients. Of course, do take a history about whether they have children and grandchildren before you move on to that. So, it actually touches the felt needs of the patient. Yeah, Dr. Om, carry on.
Yeah. So having said that, for sleep apnea, I think a lot of patients under-recognize this and underutilize. And those people who have been treated for sleep apnea by whatever means, by weight loss, maybe bariatric surgery, or, using CPAPs, they tell you that this is the best decision they
Absolutely.
I think, the quality of life improvement, there is nothing which gives you better quality of life than improving sleep apnea. Right? And patients never realize this until they start being treated for that. That fatigue which they had, and their entire day is very difficult to go through if they have sleep apnea, right? So it's a very difficult thing. And once they start getting treated, it's completely better. I think, talking about airlines, airlines always are looking at making things lighter. I mean, that itself, maybe no one always could partner with.
So the world begins with Om and ends with Om. Now, obesity as the banyan tree of medicine, what comes to your mind, and what would you like to share with our audience?
So I think for me, the take-home message is, go home, or you're probably at home, calculate your waist to height ratio. Okay, very simple to do. You know your pant size, or you can probably ask, or measure waist yourself. And you already know your height. Mine is 0.48. If it's more than 0.5, you are, probably a candidate for what we discussed today. So I just, was under the radar. So yeah, so happy for that.